Okay, other than seizures and strokes, what else can cause an altered mental status? Well, we have this acronym we can use, aeiou-tips. What are the causes? Well, it could be from alcohol. Someone's consumed alcohol or other drugs. They could have epilepsy. They could have had a seizure. Could be in the postictal state. Intoxication, opiates. Uremia is a buildup of waste product in the blood. Could be trauma. Maybe they hit their head and that's why they're having an altered mental status. Temperature. Are they too cold or too hot? Could it be an infection like meningitis? Could it be poisoning? Could it be psychogenic? Like it could be they're going into shock. Could be a seizure. Could be fainting. Could be a stroke. So there's a lot of different causes of altered mental status. Okay, hypoglycemia. So the symptoms are going to mimic a stroke and a seizure because their brain is not getting enough sugar. Delirium is another cause of altered mental status. This is a symptom. Delirium is not the thing called, delirium is the way to describe the altered mental status, but something brings that on. It's a new complaint. It's sudden. It just kind of comes out of the blue. There's usually a physical cause or a mental cause. Maybe they had a bad medication interaction. Maybe they're under a lot of stress. Something like that, where they just suddenly get confused. It can be reversed really easily, and they're basically just going to be confused. They're probably going to be scared because it kind of comes on suddenly, and yeah, usually goes away just as quick as it came on. Other causes of altered mental status: a head injury, intoxication, psychological disorders, medication complications, again, especially medication interactions, infections, especially an infection of the brain or infection of the bloodstream. Scene size up. Anybody who has an altered mental status gets high flow oxygen. We don't know what's causing that altered mental status, so we want to give them oxygen to try to make sure their brain's at least getting enough oxygen. We want to make sure that oxygen saturation is at least 94%. There are certain scenarios where you can do what we call hyperventilation, which is where you use a BVM or a pocket mask and you give them a breath every 3 seconds instead of every 6, so that you're giving them a bunch more air. At the EMT level, we don't really learn exactly when and how to do that, when to do that. So for me, I just say, you know what, if medical control or a paramedic tells you to hyperventilate a patient, do it. Don't do it under your own recognizance. It's not something that we really train well enough in, I don't think. History taking, we have to ask questions. Are they withdrawing from medication? Did they start a new medication? Any changes in their life? Did they recently hit their head? Do they have they ever had a stroke or a seizure? Have they just anything new? Have they do they have diabetes? Anything that could cause, any of those aeiou tips, where the questions are where we're going to figure out what was the cause of this altered mental status. The only way we're really going to find out is through asking a bunch of questions. Hopefully, if they're too confused to answer, hopefully have a bystander or a family member who can give us some information. What are their vital signs? With a head injury, whether it be a stroke or somebody who hit their head, skiing or something, the symptoms are the same. They'll have a slow pulse, erratic respirations, meaning the breathing is kind of all over the place, fast and then slow, stop breathing, breathe really deep, breathe really shallow, just all over the place, and then a high blood pressure. If the pupils are changing, and they're not constricting to light, or one's bigger than the other, or they look really big or really small, that's a sign that there's something wrong with the brain. Check their blood glucose levels. We have something called the Cincinnati Pre-Hospital Stroke Scale we'll look at that we can use to test to see maybe they had a stroke. There are several other stroke scales. You'll notice the Cincinnati Stroke Scale and the FAST mnemonic are the same. Somebody's having an altered mental status, it's really important that we monitor them continuously, and any changes that take place in altered mental status or in mental status, we want to record the time and what happened. So let's say they regain consciousness temporarily. You want to write down what time that happens and then what time they lost consciousness again. These can all help the hospital know exactly what's causing the problem. Okay, so here's the Cincinnati Pre-Hospital Stroke Scale. You're just going to check 3 things. You notice the words are facial droop, arm drift, and speech. So FAST is facial, arm drift, speech, time. So that's why it's the same as the FAST mnemonic. Those are the 3 things we're going to check. Facial droop, ask them to smile or show their teeth. If you can see that their face, one side doesn't move, then they have facial droop, or one side doesn't smile as much. Arm drift, you can ask them to close their eyes, put their arms out in front of them. If one arm goes down or one arm doesn't come up, or you see one arm being different than the other, then they have arm drift or paralysis of one arm. Speech, ask them to say the sky is blue in Cincinnati. Cincinnati is difficult to say if you're slurring your speech. So if they slur their speech, you'll know they have slurred speech. Or if they can't say it at all, you'll know they have problems with their speech. Okay, Glasgow Coma Scale. I think the first 4 eye-opening should look pretty familiar to you. Spontaneous eye-opening, in response to speech, in response to pain, or none. Doesn't that sound like alert, verbal, painful, unresponsive? It's AVPU. It's just AVPU, the first 4. So that one should be a breeze. Then we move on to the next one, and we go to verbal response. Okay, I like to start at the top and just say, okay, 5 is oriented conversation. That's just brains working well. What would be a little bit worse than that? Well, if they were confused, that would be bad. So that'd be 4. What would be a little bit worse than that? Well, they were talking to me, but they weren't making any sense. They're using inappropriate words. They're telling me apple Tuesday, tomorrow blue. Okay, well, that's inappropriate words. They get 3. If they aren't even using words, but they're just making babbling sounds, that's 2 points. If they can't make any sound at all, they get 1 point. Motor response, you need to remember, starts with 6 points. What's the best motor response? Hey, squeeze my hand, and they squeeze my hand. That's obeying commands. They get the full 6. If they localize pain, so if you pinch their arm and they move towards it, think about if you stub your toe on something. The first thing you do is you bend down and you grab your toe. That's localizing pain. That's normal. So if they're not obeying commands, but they at least localize pain, they get 5. If they don't localize pain, but they at least pull away, that's withdrawal to pain. So if you pinch their hand and they don't move towards it, but they pull it away from you, well, that's 4. Abnormal flexion would be that they're curled up in a ball. At least they're trying to protect themselves. They're curled up in the ball. They get 4. Excuse me. They get 3. That's one worse than withdrawing to pain. If they have abnormal extension, that means they're basically extending out all their joints. So their arms are straight out, or their legs are straight out. Maybe even their wrists and their feet are straight out. If you watch UFC fighting or street fights, you see this a lot. When somebody gets hit in the head and they go down and their body gets kind of like stiff, that's abnormal extension. That's 2 points. And if they're lying there limp, they're not curled up in a ball or anything, they're not responding to pain in any way, they get 1 point. So you notice the minimum score on here is 1 plus 1 plus 1. So 3 is the lowest score anybody can get. 4 plus 5 plus 6 is 15. 15 is the highest score anybody can get. So when you report a Glasgow Coma Scale in the field, you really want to report it like, my patient is a 4, 4, 5 on the Glasgow Coma Scale. And that tells the doctors exactly what it is. You give them all 3 numbers.